Hello, everyone, and welcome. Thank you for joining us. Wow, this is great. The webinar is full at 101 attendees. This is awesome. I just wanted to let you guys know, well, first of all, I am Stephanie Hansel. I am the president of the Lehigh Valley chapter of PAHCOM. We are hosting a two-part webinar tonight. We'll get started very shortly. I just wanted to let everyone know that all the attendees are muted, so you cannot speak. There is a chat feature where you can ask your questions, and we have two fellow Lehigh Valley chapter members who are monitoring those questions, who will be able to do them when the question and answer time has come. So first off, we have Jennifer Swinnich. She is Director, Practice Support at the Pennsylvania Medical Society. She is going to speak on telemedicine and COVID-19. Her agenda is going to go over definitions, types of services, Medicare policies, other payer policies, regulation, enforcement, and other resources. Again, there will be time for question and answers following her presentation. If you have questions, please submit them in the chat box. All attendees are muted. Following Jennifer's presentation, we'll take about a minute break so that we can transfer everything over to our fellow Lehigh Valley chapter member, Brenda Foose, who's going to do part 2 on PPP, the Payment Protection Program. So I'm going to hand it over to Jennifer, and she can begin. Thank you, Jennifer.
Thank you so much, Stephanie. Welcome, everybody, and thank you for joining me this evening as we talk about telemedicine and COVID-19. And I'm going to get the slides moving here. Stephanie covered many of the topics that I'm going to be talking about tonight, and I just want to preface this by saying it's going to feel a little bit like the Wild West, where, you know, there isn't necessarily a whole lot of uniformity and a whole lot of cohesiveness. I'm going to do my best to answer your questions, and I hope that you will take a lot from this, but mostly that there is a lack of uniformity, and we are advocating for our physicians and our practices that there needs to be some sort of standardization here. So with that, I'm going to dive right in. I want to make sure that you have a solid understanding of some of the terms that are traditionally used with telemedicine. And then we're going to talk about how these may apply or not apply during the pandemic. So telehealth in the past has traditionally meant the broad spectrum of healthcare-related services. It's a much wider, all-encompassing term to indicate a vast array of services that are delivered through some sort of telecommunications. And then within that very broad definition is a segment designated as telemedicine. It's a much smaller subset that's related to medicine and medical services, typically rendered by a physician or other advanced practice non-physician practitioner. You'll see how that will affect policies in the next few slides, because what we're going to see is that not everybody adheres to or recognizes these traditional definitions. As far as synchronous and asynchronous goes, synchronous is that real-time, back and forth, live communication, what we're doing here tonight. But it has an audio and a video component. It's real-time, it's live, and it's audio and video. And that's what synchronous means. Asynchronous is more of a story forward. I'm going to record this and play it for you later. As what may be happening with this broadcast tonight, it may be recorded and made available at a later date. That would be an asynchronous definition. And then we have originating sites and distant sites. Originating site is traditionally the location of the patient, and traditionally that patient has been in some sort of medical facility. But now we'll see how that expands to other areas as well. And then the distant site is where the clinician is located, who also used to traditionally be located in a facility, and that may not be the case during this pandemic as well. So next I want to talk about some of the types of telehealth services and make sure that everyone has a clear understanding of what these different types are and what the requirements are. So we're going to start off with telehealth visits. Now, telehealth is what Medicare uses to describe the broad range of healthcare-related services. But in Medicare's definition, Medicare actually describes telehealth as the smaller segment of telemedicine. So it's kind of the opposite of what I just showed you on the previous slide. Telehealth is a type of visit. It's a type of service within telemedicine as far as CMS uses that definition. Now, when the pandemic was identified and we started hearing about stay-at-home orders and what are essential services, what are elective procedures, there were many instructions that were coming out. There were many definitions and interpretations that were coming out, and CMS had announced a waiver, a suspension and an expansion of telehealth services. So they removed many restrictions, and that includes the restrictions that the patient had to be located within the facility as the originating site. And it also removed the restriction that the physician or clinician had to be located within a facility at the distant site. And they also removed the rural restrictions where telehealth was only used within specifically identified locations. So those restrictions were lifted, opening up telehealth to all Medicare beneficiaries, regardless of where they were located and regardless of where their clinician was located, barring any state licensing issues, which I'm not going to touch on tonight. So it removed that restriction and opened up this benefit to the beneficiaries. But this segment of visits is still identified as being synchronous. It still has a requirement that there is audio and video and that it is a real-time communication. It is a number of services traditionally identified as your E&M services, whether it's in the outpatient clinic, in the emergency department, inpatient, your nursing facilities, observation, etc. And they have broadened that expansion as well, where it now includes a number of behavioral health, physical therapy, occupational therapy, speech therapy, and many, many other services. And they have been adding other services as well. So if you have other types of providers within your practice, you'll want to check out the hyperlink that I have on the slide here to see if those services are included in telehealth, because it would be impossible for me to list them all here on one page. There are many, many services that are listed. Now, also, I want to mention that this is now open to new and established patients. Traditionally, this was reserved only for established patients, and CMS has also expanded that to new patients as well. Now, in the past, you used to have a consent for providing telehealth services. And that's why it was reserved for established patients, because you would get that signature from the patient when they were in the office, and you would get your consent that way. Well, since this has been expanded to new and established patients, the consent is still required, but it's a verbal consent. So a verbal consent is allowed. You would just document that within the notes of the service that was rendered. Now, in the past few, I'd say a week, 2 weeks, honestly, it's all a blur anymore. It feels like Groundhog Day, kind of. CMS expanded telemedicine coverage to include telehealth visits. Now, this is separate from the telehealth. These are specific to telephone. This means that they are audio only. There is no video component. And under Medicare, this is specific to established patients, and it's specific to the CPT codes that are listed on the screen. CMS expanded reimbursement for the telephone visits because they've heard from many physicians and practices and associations, and other stakeholders that the Medicare population may not have the technology to be able to have a live audio and video interaction, or they may not even have the aptitude to be able to do that. And I think of my father, who is a Medicare beneficiary, and he has the traditional phone that plugs into the wall and doesn't have a smartphone. And there are many Medicare beneficiaries that are, that have the same aptitude or technology available, the telephone, that's it. So Medicare opened this up for reimbursement, but it is specific to phone calls. Now, there's also another section of telemedicine called the virtual check-in, and this also has a code that is available for reimbursement as a phone call. The G2012 is a brief telephone check-in, and actually this code was established as a reimbursable code with the Medicare physician fee schedule, and this code was not part of some of the expansion that was made available, with the start of the pandemic. This actually goes back to the beginning of the calendar year as a new reimbursable code. So the G2012 is for a brief telephone check-in. The G2010 is for a recorded video that might be submitted to the physician and then reviewed, or it could be a picture. And there was a practice administrator who asked me, well, when would I use something like that? And I was talking to an internal medicine administrator who had asked that question, and I'm trying to think of a way that this might apply. And everybody they're working from home or they're staying at home. More people are cooking at home. What if you had a patient that sliced their finger and they weren't sure whether they wanted to go in and get stitches, or did they really need the stitches? So they take a picture of it, send it to their doctor. Hey doc, what do you think? And the doctor could say, that looks pretty bad. You need to go to the ER, or I'll tell you what, I'll meet you at the office. I can stitch that up for you real quick. That might be an example of using that code. Now, if they would go into the doctor and the doctor would stitch it up, that would have resulted in an office visit. It wouldn't necessarily be appropriate to use that code. So you've got to look at the CPT instructions with these codes as well. There will be requirements with them as well. But the virtual check-ins, they're asynchronous. These are store and forwards, or they're audio only. And these are available for new or established patients. And then I want to talk about e-visits. These e-visits are a way for your established patients to communicate with your providers through the patient portal. So this allows for, the back and forth communication through the portal, and it is billed as the time spent over, the cumulative amount of time spent over the 7 days. This is asynchronous because there's no audio, no video component to it, and it is not like a real-time communication. The CPT and HITCM-PP codes are there for those. They are time-based codes, and this is a service that is for established patients only. Now, the groups of codes that I've addressed here are the reimbursable codes that Medicare has identified. What we're going to talk about with the other payers is that, bottom line, if there's anything that you take away from this, there is no uniformity. And payer policies are changing day to day. And the Pennsylvania Medical Society has put together some resource material, and I'll tell you what, as soon as we get this resource together, we're finding out that payers are changing their policies yet again. We had a payer, as we were preparing the resources, there were actually two payers that had changed their policies from the time that we had started the resource to the time that it was finished. And just as soon as it's finished, it needs to get updated again. They are continuing to update their policies. I got a call from an administrator today. They had looked on one of the payers in Pennsylvania. They had looked on their website, and they had identified what they thought was their policy on telephone calls. And in talking with them, we go to the payer's site, we pull up the policy together. We're on the phone, we're both on our computers, we're pulling it up. And sure enough, she says to me, well, that's not what was there last week. And I'm like, you're right. They're continually changing. So no matter what you're reviewing, it might be helpful for you to document when you're pulling it up. It might be helpful for you to print it out where it has a date stamp to it. When you're looking at the payer policies, pay attention to the revision date, because they are marking those policies as the last revised date, and we are finding that they continue to change. So when you're looking at those policies, some of the things to pay attention to mostly is coverage. When we talk about those 4 groups of codes that Medicare has identified, the telehealth codes, which are your E&Ms and other various codes, audio and video, or is it telephone-only codes, or could it be your virtual check-ins, or could it be your e-visits? What is that payer covering? You'll want to identify which groups of codes they are covering. Do they give you any instructions for modifiers? When CMS first came out with their instructions on billing telehealth and telemedicine, the instruction was to use a place of service 02. Don't anybody write that down. Do not write down 02, okay? That was the original instruction from Medicare, and that was to indicate that the place of service was delivered via telemedicine. However, when remittances started to be processed and physicians started to receive their reimbursement, they found out that the rates were paid at facility rates because of the old requirement that the clinician be located within the facility. And so using that O2 in Medicare's terms didn't solve that problem. It lost that payer parity. So now the instruction from Medicare is don't use the O2. Now we have seen some of the payers adopt that same direction, do not use O2, but some of the other payers still have that instruction. And so we're not sure yet whether they're going to modify their policies just like Medicare has or not. And that ties into, I mentioned O2 in the place of service, but the modifier is some payers will instruct you to use a 95 modifier. Some payers will instruct you to use the GT modifier. Medicare's instruction is to use the 95 modifier, but the payers are not all on the same page. There is no uniformity. You'll want to see if there is payment parity. Are your physicians and other practitioners going to be paid at the same rate as if the visit was face-to-face? And that may be so, that may not be so. That is something that we are also continuing to watch. And some of the payers have revised their policies to follow Medicare's lead, and they are saying that yes, there will be payment parity, but not all of them have adopted that as of yet. We're hoping that they do the right thing and adopt those policies. You'll also want to notice within the policy whether the payer is allowing the telehealth codes to be audio only. What are their requirements? Do they require the audio and video component, or will they allow the audio only aspect? When I was talking with a different administrator earlier today with her questions, we pulled up United Healthcare's policy. Now, United Healthcare was actually one of the first payers to reach out to PAMed and say, here's our policies. And in a nutshell, we're following Medicare's instructions. When the administrator and I looked at United Healthcare's policy earlier today, there was a statement on there that allowed either audio and video or audio only, specific to the E&M. So I'm just encouraging you to review the payer policies. They are always changing. And now I think maybe you get the statement of the Wild West. I don't want to say it's a free-for-all, but there's new information that comes out every day. Everything is evolving, and there is nothing that is constant. The only thing that's constant is that everything's in flux. That's what's constant. Everything's in flux. Lastly, I want to talk about documentation. Medicare has actually released documentation guidelines for the telehealth visits. Now, you may have heard that documentation was being relaxed in 2021. What CMS is doing is adopting that documentation earlier. So during the course of the pandemic, E&M visits can be based on either time or medical decision making. We have not heard of any other policy or payers change their policies to reflect that documentation change, but we are watching for it. We are listening for it. I want to talk a little bit about cost sharing because this has been the subject of many other questions that have come in as well. So the Families First, the Coronavirus Relief Act, the FFCRA, and the CARES Act, they both have a stipulation in there that cost sharing for COVID testing, there is no cost sharing. they are to be covered at 100%. And that applies to all of the government-based insurance, which is, your Medicare and your Medicaid, but it also covers the employer plans and the commercial plans as well. So there is no cost sharing for COVID testing, regardless of the insurance. For Medicare, the instruction to the billing instructions to the physicians and other providers is to use a CS modifier on those claim lines to indicate that no cost sharing would apply to this. And if you've already billed for testing to Novitas, I would suggest you reach out to Novitas and make that correction, because you will be paid then at 100% instead of at the 80%, with the amount going to co-insurance or deductible. And that will be effective for the antibody testing when that becomes widely available as well. When it comes to other parts of cost sharing, you may have heard of different payers' policies, and I just want to draw some distinction between some policies that we've seen. Some payers are covering the cost sharing for the COVID-19 treatment as it relates specifically to hospitalization only, and some other payers have extended that to whether it is hospitalization and other treatment, which would include, office visits, etc. And some other payers have included telemedicine cost sharing, in their cost sharing policies for COVID-19 treatment as well. And there have been questions from patients coming into their practices about cost sharing for telemedicine, any diagnosis. So you'll want to be clear from the different payers' policies on what services have the cost sharing been waived for. Is it for hospitalization? Is it for all COVID-19 treatment? Is it for COVID-19 telemedicine? Or is it for any telemedicine? So you'll want to be clear on that. As far as cost sharing goes, in the past, practices were always instructed to not waive cost sharing or not waive copays for fear of the OIG coming down on that. And the OIG has issued a statement that they are using enforcement discretion for any practices that do waive the cost sharing portion of telemedicine. This is a decision that you'll make for your practice on, how you are treating any potential cost sharing with telemedicine. How would you collect copays and co-insurance for that? So if it makes sense for your practice to waive that a little more routinely than you have in the past, the OIG is not going to enforce it. So as far as other regulations that have been waived, this was a big one when we saw this. The OCR has announced that they will not be enforcing the requirement that you're using HIPAA-compliant technology when you are offering telemedicine or telehealth services. That has really opened the door for physicians to use more commonly based technology like Skype or FaceTime, anything that has a one-to-one communication. When you have, if your physician is using, I know that there's ways to talk over Facebook. You want to make sure that that communication is one-to-one. When it's like a Facebook Live and it's going one-to-many, that's still a no-no. You can't do that. So always be careful that you're using a one-to-one communication. And this is just a temporary relaxation of the rule. They're not actually getting rid of the rule. OCR is just saying we're not going to pursue it. We're not going to, issue fines or anything like that. But you've got to be responsible with it by making sure that you're using that one-to-one communication. Now, if you are working towards getting your physician set up and comfortable using telemedicine, and you want to use a vendor that is HIPAA compliant, and you want to start this off on the right foot, you can get a list of vendors available on our website. If you haven't been to our website, I want to let you know that we have a bunch of COVID-19 resources available, including information on telemedicine with hyperlinks to the different payers' policies and the hyperlinks to the CMS codes that are all included in, in their telehealth policies. So with that, I really want to hear from you. I'd like to hear your questions, hear your concerns, and we'll talk about how PA-Med is continuing to advocate for physicians and their practices during the time of tremendous flux.
Thank you, Jennifer. Okay, we can start with questions. Suzette, can you start with some questions?
Hi, thank you. I'm looking in our chat, so if anyone has questions and you would like to post them, please post them and we'll share them with Jennifer. Steph, right now I'm not seeing anything. Are you seeing any questions?
I have a couple hands that were raised. One question from Whitney: can telemedicine be used when the patient is unresponsive?
When the patient is unresponsive. I imagine that the communication might be with a family member. I'm thinking maybe, I'm not sure. If they're not responsive, I'm kind of thinking that maybe 911 would be the appropriate way to go.
Okay, maybe she can elaborate if you didn't answer that question. The next question: is it okay if the doctor calls the patient at the time of the appointment for telemedicine?
Whatever sort of workflow is going to work best for you. There are the e-visits through the patient portal, and I can go back to that screen. The e-visits, which are the ones that go through the portal, they are patient initiated. The patient sends you the message, and that's how that process starts. But if you're having a telephone visit or a telehealth visit, you can have the physician call the patient at a particular time. You'll want to look at your workflow and see, what's your process going to be for that? Are you going to, have a schedule of patients and allocate time and, let the patient know that, okay, Dr. Smith is going to be calling you between 2 o'clock and 3 o'clock, so be ready, or you'll have to identify what's that workflow going to look like. But yes, it would be okay for the doctor to contact the patient,
okay,
for that appointment.
Next question: are the telephone codes 99441 to 43 reimbursable for the FQHCs?
I know that FQHCs have their own set of rules. I can't say with 100% certainty. I think that they are, but I would want to double check that. And that's something that I can follow up on.
Okay.
Okay.
What is the difference between telephone visit 99441 and the virtual check-in brief telephone check-in G2012? It's confusing. Can you elaborate the difference?
Sure. So the G2012 is a reimbursable code that that was reimbursable before anybody ever thought of coronavirus. It is meant to be just a 5 or 10 minute phone call, just as it is, a brief check-in. When physicians and other practitioners found out that this was the only code that was reimbursable through the whole telemedicine expansion during this pandemic, CMS identified these codes as now reimbursable. So the telephone codes, number one, are only going to be temporary. They're not going to be reimbursable once the public health emergency is over. So that's one of the first items to differentiate. The second is that these groups of codes, the 99441 through 43, are for physician phone calls, and there's a number of different codes there to identify the time that's associated with each of those phone calls. So as the number increases, the time is going to increase, and as the time increases, so does the reimbursement dollars that increase as well. Now the 98966 through 98968, those are your non-physician clinicians that are using those codes. And so they are also time-based, and they have their own reimbursement assigned to them as well.
Okay, thank you. During this time, many rules and restrictions have been removed or suspended during the COVID-19 health crisis. Please clarify these rules have or have not changed. The first one is, can a practice bill Incident 2 for mid-level telehealth visits when a physician is in their home providing telehealth visits and the mid-level is in their own home providing telehealth visits?
So Incident 2 is one of those billing scenarios that this is really going to be interesting. I have not seen Incident 2 specifically addressed with telemedicine, but it's something that I would be willing to reach out to CMS for to get additional clarification. What we have seen, though, is supervision has been relaxed, if you will. When physician supervision has been required with particular services, CMS has actually allowed, they've identified that physician supervision can happen through video. Now, whether that extends to the Incident 2 requirement, I'm not entirely positive, but I would be willing to reach out to CMS and see if they've made a determination on that.
Okay.
That's a good question.
Another question or clarification, if you could, can you confirm that a mid-level service can only be billed if the mid-level is credentialed with Medicare and has a PTAN number? Many practices still think they are not required to credential mid-level providers, and these services can all be billed Incident 2 under the provider and paid at 100%. Can you clarify where the commercial carriers stand on this same issue? Some of them do not credential mid-level providers.
So the rules vary between nurse practitioners and physician assistants. Medicare will credential both PAs and NPs, and so that you aren't stuck in what may or may not qualify as Incident 2, it's a good idea to credential your providers. In fact, many of the payers are offering provisional credentialing, It's all expedited because they don't want patients and their members essentially going without care. So if you need to get your mid-levels credentialed, this is the time to do it. As far as nurse practitioners go, most payers will credential them. When it comes to physician assistants, though, not every payer will credential physician assistants. They all have their own rules, and that's something that you can usually find in their provider manuals online or their credentialing instructions, but they when the payer does not credential the physician assistant, typically the billing is submitted under the supervising physician NPI number, and they're typically supervising, meaning that they're available by telephonic means. So that would still, you would still be able to do that in the telemedicine world, provided that there's nothing else in their telemedicine policies that require anything else.
Okay, thank you, Jennifer. From William, what is needed to be listed as a vendor? And he lists a website, https://store.webchart.app telehealth.
So we actually pulled the vendor list from one of our colleagues. The Texas Medical Association had an existing vendor list, and we linked to their vendor list. But if this question is coming from a vendor who would like to be listed, my contact information is on the slide. They can send me their information, and I will forward it to our COVID response team.
Okay. Next question, any update on RHC billing?
There are always updates to RHC billing, and I know that there's a different set of rules for RHCs, just like there are for FQHCs, and I just don't have that familiarity right now. But if there are specific items that they'd like to know, that's something that I can follow up with.
Okay. Do you use POS and modifiers for telephones and patient portal communications?
You're going to want to check the payer policies, but for Medicare, you will use Modifier 95.
Okay, next question. So if we are not to use place of service code 2 now for Medicare, are we just supposed to use our regular office code?
That's a really good question. Medicare's instruction is to use the place of service that you would have normally rendered that service, in a face-to-face setting. So if it was an office visit and you would have normally rendered that service in your office, you're going to use place of service 11 or whatever, whatever you happen to be doing. If it's in the nursing home, you would use that place of service code. Wherever the face-to-face would have normally happened, that's the code that you're using.
Okay. What does it mean that patients should initiate the telemedicine visit?
So with the e-visits, and those are the visits that are specific to the portal, they're initiating that communication through the visit. Now, it's okay for you to let your patients know that you are now offering these services, but they've got to be the one that's coming to you and saying, look, I'm having this medical concern, and I want to, I need to talk with you about it. They don't want, that instruction is there to prevent, and anyone that's doing this, out of, a disingenuous, they want to prevent anything that's disingenuous.
Okay. Another question, can telemedicine be used for transition care management?
That might be on the list of telehealth codes. I am not sure off the top of my head, but I can take a look and follow up with you on that.
Okay. We're going to go back to Whitney and her unresponsive question. She elaborated more. If the patient is on a ventilator in a hospital and the hospitalist views the patient through a certain video app, the patient is unresponsive since they are on a ventilator. The hospitalist does not communicate with the patient at all.
That's an interesting question. I don't know if I can answer that, but I would be willing to pose that question to CMS.
Okay. When is Pennsylvania Medical going to enforce payers to be consistent and not continue to change their policy daily? I am trying to educate our physicians and feel like a fool as I keep having to change how they are recording their charges.
I feel for you. We are really advocating for the physicians and their practices. Unfortunately, some of the policies that are coming out from the payers are that, they're written poorly sometimes, or they're not clear, or they're interchanging words. And I don't think that it's anything that they're doing on purpose. I don't think that they're trying to be vague. I think that they're, really working as fast as they can to get something out there, and then it's not, it's not going through the usual scrutiny that policies are getting because they're in a rush to get it done. I wish we could enforce that they are all following the same policies. We have written letters to the governor. We have written letters to the legislator. We have signed on to letters with the AMA that have gone to the federal agencies to ask them to intercede and to require this. We have reached out to the Blue Cross Blue Shield Association, the National Association, and we've also had contact with the American Health Insurance Plans as well, another national organization. And we have signed on to these letters. We have had communications with these groups pleading on your behalf to let them know that all of this lack of cohesiveness is really, really detrimental to the delivery of the services and ultimately detrimental to the patient care. We have heard your pleas and complaints about how arduous this entire process is, and I'll tell you, I feel for you. I really do, because I know that when I'm looking at policies and you see that, oh, that changed yesterday, so that means that what I told that person a week ago isn't valid anymore. It makes me, I feel like I now have egg on my face. I can only imagine how difficult it is for you to try and stay abreast of this. I'm really sorry, but just know that PA Med is doing all that we can to try and bring some sort of uniformity, some sort of stability to your practices, and I wish I could do more. I really do.
No, yeah, we understand. It's very frustrating. This is a very unique time. We're all learning.
History. This is history in the making.
Yeah. Another question, can we use 99211 to 99215 codes?
Those are within the telehealth group, and I'm going to go back to that. Yes, those are telehealth codes. Those are your traditional E&M codes. So they will require the audio and video component. But if you are meeting the audio and video and you're doing essentially that exam with all of the, the time and the medical decision making, then yes, you can bill those codes. Provided that, we're talking about Medicare here, or provided that you take a look at the policy of the payer and make sure that you're compliant with whatever their policy may be.
Okay. This is from James. G2012 was introduced by CMS prior to the PHE. When would this code be appropriate to bill after the PHE?
That code is, throughout the rest of the year and until CMS decides that it's not going to be a reimbursable code anymore. That one was G2012 became a reimbursable code with the Medicare physician fee schedule long before coronavirus.
Okay. From Blake, have there been any changes to adapt TOC or TCM visits to telehealth? Currently, TCM visits require documented and signed consent for billing. Is a verbal consent for this sufficient for patients who are established and under the care of a specialist?
I would need to look that up. While I'm here on the telehealth screen, the link to the services is right here in this link, and there may be more instruction on billing the CCM and the and the consent for that. I know that the consent for telehealth has been permitted to be verbal. I'm not positive on the consent for CCM, but that's something that I'd be willing to look into and get back to you on.
All right, thank you. From Lori. So if a patient calls in with an issue and wants just an audio call from a doctor or nurse practitioner, is this an e-visit or telephone visit code?
With the nurse practitioner, it could potentially be either.
Okay. We know the provider should be licensed in originating site, but does the provider have to be credentialed in the distant site? Asking specifically for cases where the provider lives in a state different from where he or she practices.
Okay, so according to Medicare, they are allowing doctors to practice across state lines, but that doesn't address the state that issues the license. Now, one of the things that Governor Wolf has done is to allow physicians and other practitioners who might be licensed in the neighboring state to have expedited licensing here in Pennsylvania. But if you're talking about the patient is located in Pennsylvania and the physician is located outside of Pennsylvania, it's going to depend. Well, let me make sure that I got that right. When the patient is located in Pennsylvania, they have to have a Pennsylvania license traditionally. But Governor Wolf has relaxed that so that the physicians in the outside states can, can get that, an expedited license. When the patient is located outside of Pennsylvania, that physician has to be licensed in that outside state, and it's going to be up to that state to decide what their licensing requirements are going to be. So if you're talking about, let's say, New Jersey, you would have to look to New Jersey to see if they have made any, waivers, suspensions, or relaxed any policies with their license. And I am not familiar with any of the licensing requirements in the border states. I would direct that to New Jersey, or whatever the state may be.
Okay. So this is from Eddie. So I have a Medicare Advantage patient who initiated a call for possible pink eye. The telephone call was approximately 10 minutes. Should I bill 99441, which is equal to 5 to 10 minutes, or a G2012 for brief phone service? Both CPT are covered for members' Aetna replacement plan.
Well, I'm not a certified coder. You mentioned the medical assistance, or not, you mentioned the Medicare Advantage plan. So I would look to the policy of that Medicare Advantage plan and see if they, what their instruction is. Let's say that the Medicare Advantage plan covers both the telephone visits and the brief check-in, it seems like there is more of an exam component listed to it, so I would probably build a 99441. But that's just provided that that the payer is reimbursing for that.
Okay. A couple more questions. Is there any advice on how to find each payer's specific guidelines for telemedicine coding?
So the Pennsylvania Medical Society website, we have a coronavirus page, and we have identified a number of different topics, and telemedicine is one of those topics that, really deserved its own section. So when you go to our coronavirus page, you'll see a section on telemedicine, and you can pull up a reference sheet, and we have hyperlinks to the policies for many different payers in Pennsylvania. So where, you might see, Aetna and United Healthcare and Highmark and Capital, you can click on those, payer names, and it will take you to the policies so that you can, you can pull them up and print them out and have them for reference.
Okay. We're going to take one more question. I'm looking for Medicare, we are to bill the POS code that we would have otherwise reported, but what about for Medicaid? Florida, please.
I am not sure off the top of my head. All of the payers have set their own policies, so I would have to double check that.
All right, here's a quick one, I think. Patient calls for a refill request. How would you bill?
If it was telephone only, that could either be the brief check-in or one of the telephone calls. Is it just a simple, quick refill, not too much with it, or do they have a condition or maybe multiple conditions that you need to dive in and discuss a little bit more? You're gonna look at what level of service was performed, how much time was spent with them. The brief check-in doesn't really have, specific things that need to be discussed. That brief 5 to 10 minutes, you're not necessarily discussing specific things. The telephone codes, those have a reimbursement that is tied to the time, and so the longer the time that you're spending, the more time that you're going over, the different parts of the, of the patient's condition, it might be more appropriate to bill those codes. They were
okay.
the recent. Can I just say more about the telephone codes? Medicare, established a reimbursement to them. G2012 wasn't enough, and so you know, it's like trying to plug a dam. You know, this is just poking the finger in the crack in the dam. It's not going to, you know, it's to help solve, you know, some of those issues that are, you know, that you're on the phone a whole lot more and not necessarily having a video visit. It's not a catch-all. It's not going to solve all the problems. We get it. We know. CMS knows. CMS knows that their beneficiaries just don't have that technology. But look to the service that's being provided, and you know, you're going to find the code that best matches that way. And you know, from what I understand from CMS, there may be more coming. There may be, you know, more codes, you know, more relaxation, more expansion. Some, you know, and we're advocating for it as best as we can.
Okay. All right, I'm going to stop the questions there. We do have a couple more, but if you want to, you know, continue to ask your questions, or after the presentation is over, in the email that you receive with the index number for the webinar is my email address. You can email your questions to me, and I will make a spreadsheet up and send it to Jennifer, and then get back to you with her answers. So Jennifer, thank you so much for taking time out of your very busy schedule during this crazy, unique time. We appreciate all the information you provided to us.
Thank you so much. And I just want to let you know how much we appreciate everything that you are doing, you and your physicians and your whole team. We know that there were some very uncertain things that are going on, and we just want you to know how much we appreciate you. So thank you very much. I'm honored to be a part of the presentation tonight. Thank you.
Thank you so much, Jennifer. All right, and I'm going to take a minute, and we're going to go on to part 2. I'm going to give Brenda Foose is our Lehigh Chapter Vice President. She is going to be sharing her knowledge. That's what we do at PAHCOM. We share our knowledge. She has some very good slides on the payment protection program that her CPA provided. So I'm going to hand over the webinar to her, and she will present PPP.
I'll be happy when I see the slides, and I know I'm good. Okay, can everyone hear me okay? I would like to welcome everyone.
They can't answer you.
Oh, well, if you can hear me, then I know they can. My name is Brenda. I am the Secretary of the Lehigh Valley PAHCOM chapter, and I welcome you to our Ultimate Social Distancing webinar. We're all comfortable in our own homes. And speaking of social distancing, I'm sure we're all thinking about that in our weight rooms and with even working in our office with our office staff. So there's different ways of social distancing even in our careers. The coronavirus created a new set of acronyms and terms that we're using on a daily basis, and I'm sure it's very exciting for the upcoming CMM and HIT exams. I will be a moderator for this section. I'm not an expert on this, and of course, everyone should refer to their CPAs and legal counsel for your resources. This is a safe zone, so I want everyone to feel comfortable asking questions at the end, sharing your experiences. This is where we get our greatest resources through PAHCOM, sharing our knowledge with each other. Before I start with the slides, the other couple things that I wanted to mention, I'm hoping everyone can hear me okay, I'm getting beeps. First thing is the CARES Act for the Provider Relief Fund. Most of us, apologize. Do you have the size up there, Steph? You took the control?
I'm going to take it back.
Okay, I didn't move. I'm still on that first one.
You're still on. You're still here.
Yeah.
Okay,
Yeah,
just tell me when to
there
advance.
Yeah. Okay. No, I just wanted to say that hhs.gov is a great resource for you to go to see what is going on with the on a daily basis, to see what the changes are. We all woke up on Friday and Monday with this CARES Act Provider Relief Fund in our accounts, and some of us were wondering what exactly all that means. So go to the hhs.gov. You will see that it says these payments are not loans. They're the healthcare providers and do not need to be repaid. However, there's always a click. There's a condition to receiving these funds. And starting this week, we're to go back to the site, and we're supposed to do an attestation confirming the receipt of the funds and agreeing to some of the conditions that are on there. I would love to hear at the end. I have not done this yet. If anyone that has done this already this week and can share your experience with that, that would be interesting to hear. And aside from that HHS payment, there was also another resource that was given to practice, and that's the CMS Accelerated Advanced Payment Program. Again, if you have done this and you can share your experience towards the end, I would love to hear some add-ons on that. And the last thing I wanted to say before we started on these slides was, now we're all going through these periods of deciding if we have to, with our reduction in our practices, about laying off and furloughing. And that was something that I had to learn about, because we never had to do a layoff or a furlough. And that's also described on your unemployment sites. But basically, a layoff is when you're actually terminating the employee, and a furlough, you're generally going to recall them back, and you're giving them a note so that they don't have to apply for other jobs. And now that's in Pennsylvania what they're doing, so I'm not sure maybe in some of the other states. But there is a difference between a furlough and a layoff. Okay, so what is the Paycheck Protection Program, otherwise known as the PPP? And okay.
Can you share? Oh, there you go. Can you go to the slideshow?
Can I go to slideshow? I don't know. Is that okay to see the? All right. Sorry, this is the way we did it last night, so I just know how to do this. But at any rate, let's keep going. So this protection plan is loans that have been made by the SBA for the practices with 500 or fewer employees, which is probably everyone that's listening on the PAHCOM webinar. The issue is that the funds are running low. So if you haven't done this already, you should go on and start the process. The loan is payable back in over 2 years with a 1% interest, but the goal of most practices is to try to get this loan forgiven. The way you do that, and it's all explained when you go to apply, is you must utilize the loan that they approve you for, 75% of it towards your payroll expenses. You have other things that are on a different slide that'll tell you some of the other eligible expenses you can do, but 75% of it should be related to payroll expenses if you're trying to get them maximized with the forgiveness. Is your business eligible for the PPP loan? most of us here listening would be if you have 500 or fewer employees and you are working since 2/15/20 in the U.S. The program runs through June 30th, so you have until June 30th to apply, but again, the round one of these funds is running low, so you should probably act now to apply for this loan. It's something that you usually go to the banker that you use that knows you. That doesn't always work, and I know some people have gone to other banks because they weren't getting the cooperation with their bank, or maybe they weren't going to be on the SBA list. But the sooner you get in, then you'll get a closing. You'll have a document that you have to sign, 3 pages for your president and co-president, for example, and you submit that, you have a closing, and then your funds should be there. Now, from what I've seen, I haven't seen a lot of banks that have given the money yet. I'd like to know what banks you have experience with. I know Key Bank has released their funds. I've been checking every morning and every evening with ours, and we have not received ours yet. So that would be another interesting thing to share. Most practices, if you have independent contractors, they don't want to be included anyway because they're doing their own PPP for themselves. Just want to go back up to here again. Okay, so that's if you're eligible. How much can you borrow? There is, you go back to your 2019 payroll records and you take the average of the whole year, and you can borrow up to 2.5 times your average payroll for taken in the year of 2019. You're also getting the average FTE, full-time equivalent, for head count that you need to keep an eye on. And that's what your goal is for this year, that you need to try to match with. Some of the things that you can use these funds towards is the group insurance, health insurance expense, minus what the employees cost bear in their payroll. You would have to deduct that. And also the retirement contributions that the employer makes, not the deferred amount that the employee makes. The compensation goes up to 100,000 max, and anything over 100,000 would not be included in this. A furloughed employee cannot receive paid leave and unemployment comp benefits at the same time. That's one of the things that you might want to keep in mind when you're considering to furlough an employee. And this is where it highlights about the deducting the employee contributions and the retirement deferrals from your total amount. Then there's something here about the federal taxes, which may or may not, they're suggesting that you should deduct it from your payroll costs, but there's some things that aren't completely cut and dry yet, and I will be visiting it myself once I have the funds to start using it. You can only apply for one PPP loan. So any practices that want to try to get a loan in there's different other kinds of loans that are out there, but once you do the PPP loan, that's the loan of choice that you're probably going to be using and not any of the others. Keep that in mind with that loan. The interest rate is 1%, and that's for anything that's not forgiven, and you do have to pay it back. Originally, it was going to be paid back in 10 years, but now they've shortened it to 2 years. So it is a 1% loan, which is a nice low interest loan, but you'll have 2 years to pay back any part that's not forgiven. You can defer for the first 6 months before you start paying, but remember that the interest does accrue on the loan during that 6 months that you're waiting. then it mentions the EIDLs, the economic injury disaster loans, will be refinanced as part of the PPP, and it's that part of a loan is not eligible for forgiveness. So if you're trying to maximize on these loans and you want to maximize on the forgiveness part, this is the part that you want to pay attention to. You want to open up, and this will explain this a little bit later too, a separate bank account to keep these funds separate, because you're going to have to chart and paper trail what you're using the money for. So later, if you're asked and you need to give details, it'll be easier on yourself to show that you use 75% towards payroll and other eligible costs. But you got to, like I said, keep in mind the 75% of payroll expense, and the payroll expense, you need to subtract the 401 deferral, subtract the employee health care cost share, and you want to make sure that you keep track of those amounts separately, because you want to hit that as close to that 75% and the head count. Those are the two things that you're keeping your eye on. The other things that you are able to use the funds for is your mortgage interest, but you can't do prepayments or just advanced payments to the principal. Your rent expenses, utilities, and if you have interest on debt that you incurred before 2/15, you can also include that towards these expenses, but not for loans that you might have gotten after that date. So the key is that I have asked a couple times, and I don't know if anyone has heard differently, that if there is a cut and dry answer to this, but my canned answer that I'm getting is the day that you get the funds into your account, that's when it starts to clock, and you have to use those funds within 8 weeks when the loan proceeds are available to you. So that's another good discussion afterwards if someone else has experienced or heard something on that. So that's my goal, unless I hear differently. As soon as I see that money hit my account, it's a green light to the clock clicks for the 8 weeks. Anything prior expenses to that day that it gets into your account are not eligible. And again, this is where it shows about having a separate bank account. It's not certain exactly how they're going to review the forgiveness, but you want to be prepared and have all your ducks in a row, that you're using the funds for exactly what they're listing on there. It's not required you have a separate account. It's just recommended. So most people that have wanted to try the PPP have probably already done the application process by now. But if you haven't, do it as soon as you can. The round one money is getting low. You can do it directly online. You need the documentation that's listed here to have in hand, ready to go. And of course, you can always consult your accountant. And some of the banks, like I said, that I've heard that have funded already is Key Bank in our area, but I haven't heard of other banks. I would love to hear your experiences with that. This Bill Bloss is the gentleman. He's my CPA. He's the one that prepared these slides. And it's funny because he did these like, close to 2 weeks ago, and already some of these things have already been answered or were beyond. So the payroll tax credit, who's eligible? These are the different credits. Now, the payroll tax credits, you can read these as you go down. From my understanding, you can't do both. You can't have the payroll tax credits and the PPP and want forgiveness. So some of these things are, if you want to go the payroll tax credit route, you can go here. And the rules are always changing, so that's something also that you would want to check with your CPA on. I know there's a provision I had set aside here also about the family medical leave and the emergency family first coronavirus response act funds for the sick time. And this is one of the things that I saw, that there was no credit available if you use the PPP loan proceeds. So I wasn't looking too far into this part, but someone that may have experience with this, you can share that if you're not going to go the PPP route. The employer taxes, again, the last line, you're not eligible to delay payment if you received PPP loan proceeds. But if you're not going that route, these are some of the dates that you can postpone some of your employer side of taxes to be made. This is getting into some of the business losses and some things that are generally you use from year to year, and this is giving you the amounts and some of the loss business expense things. I don't get into this, but my CPA does, but this would be of interest of someone that does some of their loss evaluations of their business on their own. This is again about depreciation. They did change some things. I heard him talking about this, that this was a correction that needed to be made in there, that you should take advantage of the correction, which is the word correction is not spelled correctly. A little irony there. Okay, this is getting into the paid sick leave and the limited amount per day, and it goes to 10 days for employees that are quarantined or seeking diagnosis versus someone that's taking care of a family person versus someone that's just seeking a diagnosis, or it's because their child care, school, or daycare is closed, which is most everywhere. So there are differences in limits per day and for the 10 days. So this is a good page to keep in mind if you're offering this, the difference between the two, the $511 a day max versus the $200 a day max is a large difference to pay attention to. And then these are some of the other Family Leave Act things, and wages and dollar amounts and the quarters. All this started not until 4/1, so it was not in effect back in March. And if you do use these tax credits, they are refundable when you do your returns, but the forms and instructions have not, at this time when these were made available. That's what I have on the PPP, but like I said, there's other things besides the PPP that we're all experiencing right now with the CARES Act, the layoff, the furloughs, the HHH stimulus funds, the CMS advance funds. So I just wanted to share some of this, and hopefully we can share some experiences on this. So if you can post some of your questions, and then Steph and Suzette can help answer some of them, this is a time to share our knowledge.
Thank you, Brenda.
Mm-hmm.
One question If you have received the PPP, what happens if employees leave on their own, or are we required to replace them in order to qualify for forgiveness?
I'm just going to make one comment on that, and then Suzette, if you have something to say. We've talked about this over and over in my practice. I don't know 100% what the answer is, but it's FTE count. So you can bring someone back off a furlough or layoff. You can hire someone during the time. It's not meant for paying, for example, overtime and things of that nature. It's just strict pay time. But keep in mind that getting 100% forgiveness is probably not going to happen. So when you're trying to decide to hire someone to take a place of someone that left, or if you can do without them for now, the difference between the amount that you're saving in the forgiveness versus the amount of money you're spending for that payroll, you have to weigh that out for yourself and your practice, which way is best for you, even if you have to pay some of the PPP back at 1% interest.
Hi, this is Suzette Benedict, and I'm the secretary for the Lehigh Valley chapter. And I'm going to agree with what Brenda has just shared with you. What I'm aware of is that your FTE count more than likely will not be exactly the same as what you reported when you did the application. And the SBA isn't going to dive into why your FTE number is different. It doesn't matter to them. If the FTE count is not exactly the same, there will be an adjustment. However, remember that through the loan forgiveness program, only 75% of the amount that you borrowed has to be covered with payroll. You can make up the rest of that with rent expenses, interest on mortgage, interest on other loans, utilities. So when you're talking about 75% of that loan needs to be payroll, benefits, or pension, a combined of those three things, you should still be able to get fairly close. I've heard the same thing that Brenda shared with you, that it's going to be unlikely you will get 100% forgiveness, but we all want to get as close as possible.
Okay, I have a comment from Tess. If you read the attestation, it says you don't have to do anything if you accept the funds. If you don't want the funds, you will need to take action.
Okay, so that's the HHH, the stimulus fund. So that's something that's good to hear. Is that what you're talking about there, Seth?
That was just Tess made that comment. I don't know if she
Okay,
can re-comment.
So if I could,
about you're not able to charge out of network. That's the one stipulation that I saw. Go ahead, Suzette.
yes, I was going to just speak on that. There are some stipulations and regulations that you have to follow, that if you're treating a COVID patient and you are not in network for that patient's insurance company, that you cannot bill them for out-of-network expenses. You cannot bill them for more than what they normally would have paid if they saw a in-network provider. So there are some regulations. There's a few other things. So make sure you read those comments and those regulations very clearly before you attest that you will provide those services and that you agree to accept that payment.
Okay, and yes, Tess did reply. She did say yes, that's what she was referring to. So thank you for that. My physician, who is 100% owner of the practice, is on the payroll. Is he considered part of the FTE?
So I'm going to tackle that one. If they're on your payroll, there are limits to payroll. So anyone that has an income over 100,000, they are included up to 100,000. They are not included on that payroll over and above 100,000. So that this happens quite a bit where physician owners, shareholders are on the payroll, and they do look at that. I know that there's some questions still out there if whether or not a shareholder or owner will be included as an FTE, but so far from the provisions and regulations that have been shared with us is they would be included as an FTE up to 100,000.
Okay, on that same note, some physician owners of the practice are not on the payroll. Are they separately eligible for any benefits?
If you included that information when you applied, it would be considered. I can't say that it will be accepted, but it would be considered as part of your application. But it would have to be included in your application.
Okay. Our practice pays 100% of medical insurance for staff. That total amount is eligible for forgiveness, question mark?
You can use that balance as part of your 75% when you apply for loan forgiveness. You can use that as part of that combined payroll, health benefit, pension piece when you apply for forgiveness of that 75%, at least 75%.
Okay. Looks like Curtis was having a question about a problem he had with the attestation site. I went to the attestation site and it states as long as you do not request that CMS take back the funds, that this simple act of doing nothing qualifies as your attestation. There is no actual place to sign, even though the assist sec or HHS said, in his instructions that there is something to sign. The link goes to CMS page with clear guidelines, but no place to sign.
I'm going to jump on that. I'm with you. I've been looking every day for the actual place to sign the attestation. We were told that that portal will open up this week. They weren't specific on date or time, just this week. I've been looking every day. If anybody else has found it, we'd love to hear from you.
A couple people, Debbie said she received her PPP from Swinnich, Georgia, and Ann, West Shore Bank in Michigan has issued their PPP funds.
Anybody from the Lehigh Valley?
Congratulations. That's exciting to know it's working.
Yeah, those are only two that commented that they got their money.
Yeah.
A question, if I laid everyone off February 1st, can I still apply and bring people back?
Yes.
Yes, you have up to June 30th to bring them back, to restore your payroll.
I have a question about that, Suzette. I know you have until June 30th to bring people back if you furloughed them. However, for this 8-week period that you need to be using this funds, is it true that you should bring them back like the day after you get the funds in your account because the 8-week clicker starts?
That is the million-dollar question.
Right, that's the part that I'm trying to nail down. I know I have till June 30th to bring my furloughed people back because I promised them so they don't have to apply for other jobs. But the question is, when do you need to bring them back? Because you need your head count back, and you need to, because you're basically the PPP. You're promising that you are bringing your people back.
you're right. It's that, when does that 8-week actually start? And it also, I have to take it back to that loan forgiveness. How much of that money has to be applied to specific items and specific payments? So if you within that 8-week period, depending upon how your payroll rolls, within that 8-week period, will you be able to meet that requirement for the payroll, include your health benefits, and include whatever contributions you may have made from the company to the pension plan? Will you make at least that 75% balance? And if you do, then your next step is looking at that FTE number. If you're not going to make that 75% balance in that 8-week period, then I would suggest you may want to consider bringing people back so that you can at least make that 75%.
A question from Asia. Does the head count for staff have to be the same staff to be forgiven, or is it just about the head count in general?
That's why they say FTE, it's just the head count.
Correct. It's just the number. It's just the FTE number.
I just lost, my computer's going crazy. Bear with me.
And keep in mind when you're doing your FTE that 2 part-time people working 20 hours equals 1.
While Steph is pulling up the next questions, I just wanted to mention that if you have a payroll company, they're very helpful in helping you pull this information. I know ADP, Paylocity, some of the other big nationwide companies, NCR, they're all out there and able to pull these reports for you. Some of them have actually created Paycheck Protection Program specific reports just to help you pull this data.
Okay, thank you, Suzette. Another question. I applied for the EIDL and PPP and stated that I hadn't received the EIDL in my PPP application. I've yet to receive either. Was that correct?
My understanding is you could apply for one or both. So it should not, one should not counteract your ability to apply for the other. Some of these loans you cannot apply for both, but my understanding is that you can apply for both the Paycheck Protection Program and the EIDL program. Of course, you know, this changes every day, so maybe tomorrow it'll be different, but that's my understanding today.
Yeah, that's very frustrating. From Kim, in the attestation, does it mean your loss in revenue have to be strictly related to COVID treatment?
No.
So they did, I've just read a document about that, an article about that. And originally, when this was set up, Medicare was saying COVID patients, COVID treatments, and there was a lot of pushback and feedback from a lot of the medical organizations saying almost any patient could be considered a COVID patient. It could be an unidentified COVID patient. So now when they say COVID treatment or a COVID patient or COVID suspected patient, the new terminology now states that any patient could be a COVID suspected patient. So Brenda's correct. The answer is no. And it's because they expanded the definition of what a COVID patient is.
Okay, thank you. Another question. So there is 1 PPP, 2 MCR advance payment, and 3, what was the HHS one?
That's the US HHS stimulus payment. It was the 30 billion that was split and sent out to healthcare providers, hospitals. It was divided. The 30 billion was divided and split based on your Medicare billings for the fourth quarter of 2019. So most of us would have seen that drop into your account on Friday or Monday. If you've not seen that, you may want to go out and look in your bank account. If you're receiving paper Medicare payments, please God, don't be. I hope you're getting those all EFT. But if you're receiving paper, maybe it's coming in the mail. But the majority of us got those payments on Friday or Monday. And that is a different program. That is a much different program. So basically, HHS and the government decided that they needed to keep healthcare facilities open, hospitals open, doctors' offices open, help us keep the lights on so we can keep treating patients.
Okay. Elisa asked, if we made our profit sharing contribution in March, but get the PPP in April, can we use the PPP to reimburse for the profit sharing expense?
My understanding is no, you can't go backwards. But that being said, if you're paying between January and today for your profit, your match and your profit sharing, I believe you can see that.
I would actually refer that to your accountant because that gets a little sticky. If you use that balance as part of your application, I don't know if you can reuse it as your reasoning to ask for loan forgiveness. I would really refer that to your accountant for verification.
I think though, moving forward from your payrolls from this payroll on, you can include your profit sharing and matching employer portion.
Some of the documents that I've read have said that you could use expenses that you paid in 2020, but again, I would encourage you to verify that with your accountant.
Okay. Kathleen would like to know, is this an opportunity to redeploy staff allocations, FTEs, and salaries for positions? Please comment.
I think that's really tough because I think that's an individual decision by organization. You know, do you need to take a hard look at your workflow, look at your actual needs, staffing needs, look at compensation contracts? I think that's really specific to the individual organization, and it's really hard to answer as a general rule. I do think that we're going to see opportunities to do things differently and opportunities where we can change workflows and streamline workflows now that we have telehealth and telemedicine. I think we're seeing ways that we can become more technologically savvy than maybe what we were in the past. Not that we'll continue using telehealth and telemedicine because, you know, those 1135 waivers are going to go away and we're going to have to go back to our norm. If we remember what our norm was before all this pandemic. But I do believe that you're going to have opportunities where you're going to be taking a hard look at your organization and looking at areas where maybe you are overstaffed, or maybe you're understaffed, or maybe it's time to relook at compensation. Maybe that's been out of whack for a little while, and maybe this is the opportunity to take another hard look at that. I will say, and I'll attest to what Brenda is talking about, that those that have had to furlough probably found that very difficult, that they've never had to do that in the past. But when you start bringing people back, are you going to need as many people? Maybe that's the question. Also, in this decision time, how many organizations took cut hours? Maybe you didn't furlough, maybe you cut hours, or maybe you did pay cuts somewhere. Maybe some of your high-end compensated team members, leadership on up, maybe there were some pay cuts just to keep things going. So hopefully that isn't the case. Hopefully that all of you were protected. But I would say that there probably are going to be changes. I think what we are used to and what we've done in the past, this pandemic has given everyone a hard shove to take a really hard look at your workflow and a hard look at what you're doing with your company, and maybe there will be change.
Okay, another question from Sarah. Can 1099s and contract labor be included in PPP?
So I'm going to answer this, even though Brenda, I know you have 1099 employees. I just found out myself, and this is just today that I found out, that when you have contract labor, that you can include them in your PPE. And the way this works is that originally the program was stated that an organization, it could be just one single organization, or it can be an organization with multiple companies underneath it. And to apply for the Paycheck Protection Program, so long as those employees all fell under the same payroll company, payroll system, or under the same benefits system, that you could include them. If they fell outside of that payroll system and benefit system, or even central management, then you wouldn't include them. But as with everything the government's been doing, they came back and made a revision to that. And what they said now is if you're contracting employees through a professional employment organization, you can include their salaries and benefits. And what you would need to do is show proof that you have this relationship with a professional employee organization. And you would do that with contract, copy of your contract or copy of your agreement. You could show that you're paying this organization, this professional employee organization, for services. So you could use that. I would not be able to speak on the 1099. I'm not as clear on that, but Brenda, you have 1099 employees. Can you talk about that?
Well, the only thing that he pointed out to me is that we shouldn't, only because most of them are going to apply for this themselves. So you have to individually ask them if they are doing it on their own, during their own PPP.
That would bring up a follow-up question then. If you do include 1099 employees, does that mean then if you get this loan that you are going to share with them?
We already made our decision. We're not including them.
Okay. So we can answer half that question. Contracted employees, yes, you can. So long as you can get that data from that professional employment organization, so long as they'll give it to you, you can include it.
Can the 1099 employee be used in your headcount?
I am not. So that's my experience. I am not.
Okay.
I'm sorry, I don't have that answer.
Okay.
I'll look for that.
What is the website to apply for Medicare Advance Incentive Payment? I cannot find it. Thank you. Do either of you know the website we can share?
There is a fact sheet on that. And Steph, I will send you that fact sheet, and you can include it in your email out to everyone with the codes to get your CEUs. And it'll have all the information to it'll have all the information on how to apply for the Medicare Accelerated and Advanced Payment. I'll send that to you, Steph, and you can include it.
Perfect. Thank you, Suzette. From Giovanna, per legal counsel this afternoon, providers will have 30 days to sign the attestation through the online portal, confirming receipt, the funds and agreeing to the terms and conditions as a condition of payment. The online portal for the attestation is expected this week.
Excellent.
Right,
Thank you for sharing.
Thank you, Giovanna. If an employee earns a commission, can that be used towards your 75% payroll?
No, that's not, my understanding is that they cannot. That it's salary, it's wages. I don't believe commissions can be included, but we can verify that.
What if furloughed staff are afraid to come back to work by June 30th?
And he can switch them to a layoff because that's the agreement. Right now, unless the CCD changes that magic date of June 30th.
I would say that's unfortunate. Hopefully by June 30th, we're through the worst of this and we can start rebuilding practices and start getting ourselves back to somewhat of a normal state.
Yeah. Does your 8 weeks go by check date, or does your pay period have to be within the 8 weeks?
That's what we're trying to get this solid answer on. I'm going by check date just to be safe. But no, that's the thing we need to find out.
Kathleen, she's just mentioned Metropolitan New York City, no money yet. God bless you, Kathleen, for being there right in the front line.
Absolutely.
I can't even imagine. If your bank has approved, will you get the funds? That's from Tess. I don't know if that question is clear.
I think I can answer that. So she's asking so what happens with these SBA loans and the Paycheck Protection Program loans is you apply through your bank. Your bank has to approve your loan before it gets pushed up to the SBA. So this is what our bank has explained to us, is that when the loan hits their desk, they have to go through it as the bank and approve it on your behalf. And then they'll push it up to the SBA, where the SBA will apply a loan number, do all the loan paperwork, push that out to everybody to sign your loan paperwork. Once that's signed, then the money's released. But the bank does need to approve that first level of your application.
Okay. Does the practice have to share money from CARES stimulus with independent contractors who are Medicare providers?
I think that goes back to Brenda's. I think that's probably going to be an organization decision. If you include them in your loan when you apply, then I would think you're going to need some sort of a agreement with them to share those funds. If you don't include them, then they apply on their own. Is that how you view that, Brenda?
That was my understanding. That then we stayed away from our 1099 independent contractors. We did not include them.
Right. Do you want to elaborate? Curtis asked, why do you state that 100% forgiveness is unlikely?
What do you get for nothing?
Well, I'm going to just use this from what talking to our own accountant. So I'm going to just share with you what our accountant has shared with us. They're saying that the SBA is going to be extremely literal when they're looking at this loan forgiveness. That's going to be extremely literal. So if your FTE count is off by, if you have 10 employees when you applied and your FTE account is off by 1 when you do the loan forgiveness, they're going to adjust your loan, or they're going to give you 10% less on that loan forgiveness. So they're going to be extremely literal on how they view and process the loan forgiveness. We all know that at least 75% of it has to be payroll, pension, and benefits. The other 25% can be rent, interest on mortgage loans, interest on other loans, utilities. But because it all has to fall within that 8-week time span, that's why the accountant is saying that the SBA is going to be really strict and literal on what they forgive. And he's telling me that all of his accounting organizations that he's hearing from talking about the same thing, they all anticipate, or not all, the majority anticipate that there may not be as many 100% loan forgiveness as we would like to see. I wish for all of you to get 100% loan forgiveness.
Giovanna just wanted to stress again, per legal counsel, the clock starts upon receipt of the funds and runs for 8 weeks.
Okay.
Thank you.
Thank you.
I
So
have
the
insurance.
clock starts ticking when the money hits the bank.
Right. This is from Carter about insurance. I heard that practices can check on overhead insurance to cover a portion of lost revenue. It seems that some insurers are pushing back on the natural disaster clause, no pay. However, I've heard that can be contested. Is that true?
I can speak for the organization I work for. We did reach out to our general liability insurance and asked for those same exact questions. And we were told the same thing, that natural disasters are not covered, the coronavirus pandemic is not covered, that there would be no type of insurance coverage for this type of crisis. I have not heard it can be contested. I'd be interested in knowing what other people have heard, or what other people were told by their general liability coverage.
Okay. So physician owner who is not on the payroll can add up to $100,000 divided by 12, the average monthly payroll, and submit application. Is that correct?
You can include that. I don't know if they will accept it as part of the application, but I would include it. There's still a lot of gray area with this application. Talk to your accountant, get their feedback. There's still some gray area on that, but I would include everything. Give them more than what they ask for.
Okay.
Remember that the bank is only going to approve, even though you ask for, you may be asking for a loan at 2.5 times your payroll. That doesn't mean that you're going to get a loan 2.5 times your payroll. So give them as much as you can.
Okay. I'm not sure if either of you can answer this. What about pediatrics that do not get Medicare money?
Are we talking about Are we talking about the US HHS stimulus payment? What are we talking about? In what reference?
I'm going to see if she replies. I'm going to move on to another one. We only have a couple more left. How many hours are allowed to be considered to be a FTE?
I
I
thought it
would
was a
think it's
standard.
anything over 30 hours a week. Is that?
Yeah, I think it's a standard 40.
30
Okay.
to 40?
30 to 40?
I don't know that it's 30. I know that it's 30 when you're talking about the Affordable Care Act and you're talking about health insurance. When you talk about an FTE and you talk about FTE hours, most standard look at it's 2,080 hours in a year for standard FTE hours. And when you break that down, it's 40 hours a week. I don't know that that's been clarified or specifically put
Okay.
into writing that it's 40, but I'm gonna look.
Okay.
Back to the pediatrics question. Kathleen did say it is for the HHS.
I know that the HHS program used Medicare data. And when I say Medicare, it's traditional Medicare. It's Medicare Part B, traditional Medicare, not Advantage plans. They didn't use Medicaid. They didn't use any other federal program to determine the HHS payment. They only used Medicare. I don't know that means that you're not eligible. I believe I did read somewhere that if you did not get a stimulus payment, that there was a contact information that you could reach out and ask whether or not you were eligible for a stimulus payment.
I think the $30 billion was limited to the Medicare participating physicians, and I think the second round, when they come out, might be more inclusive to other practices. But I do believe the first round was limited to Medicare participating providers.
I'm making a list.
Val wants to also in pediatrics, but she's in Florida. I would like to know the same, and yes, my question would be for the stimulus for Florida Medicaid specifically. I don't know if either one you can speak to that.
Today, I was trying to find information on an out-of-state Medicaid program, and everything I was reading that they're all state specific and they're all doing their own thing. There's no standardization on Medicaid across the board. Each state is allowed to make that their own decision. I would encourage you to go out to your Florida Medical Society and ask them that question.
Okay. And Deborah just wanted to express, I thought the purpose was to keep employees on during this 8-week period with a bunch of question marks.
I'm going to tell you that that was my understanding originally for the Paycheck Protection Program, that was the intent, was to keep your employees on your payroll. But then they came back with a provision that said that if you furloughed an employee, or if you had a furlough, reduced hours, or reduced compensation, that so long as it was restored by this June 30th date, that you could still be eligible to apply and eligible for loan forgiveness from the Paycheck Protection Program. This is one of those things where they put it out there and they put the program out there and they make the rules, and then they hear from all these organizations and then they come back and they change the rules. I'm waiting for them to change the rules again, because it seems like every day I'm reading a new provision to a rule that was written. It's very similar to when we first heard about the Extended Family Medical Leave Act, and we heard about the paid sick leave, where it was all of us were in it, and then all of a sudden the definition of what a medical provider was extended to include every one of us, even if we're not a physical provider, not a nurse practitioner, PA, or a physician. That medical provider definition was expanded to include all of us, where we could exclude ourselves from those two programs. So it's every time the government comes up with a plan or a program, it keeps getting adjusted and revised. It seems like what goes to the House can't get through the Senate until there's revisions and somebody else puts a stamp on it. And it just feels like we're constantly seeing new revisions and new regulations. So originally, I would agree with you that that Paycheck Protection Program was put into place for us to keep our employees on our payroll. And I believe that's still the original intent, and they're still hoping that that occurs. They just gave this extra however provision that says if you had to furlough or if you've made any changes, you could still be eligible for loan forgiveness if under these conditions and you meet these conditions.
You have to keep in mind that practices that are surgical based, if your surgeries went down the tank, how can you bring everyone back? You can promise them and give them furloughs, but how can you bring them all back? They'd be literally looking at the bare walls. There's nothing to do for some of your staff, and if you're in the surgical realm.
Well, and as Brenda's saying, there's other specialties. So ophthalmology, look at dentists, all across the board, derm, there's all across the board, there's specialties that have literally just shut down until they can get past this crisis.
And yet we don't want to lose our employees, so we are going to bring them back as soon as we can and as soon as things ramp up. That's the big difference between a furlough and a layoff. We don't want to lose any of our employees.
With the furlough as well, keep in mind, with the furlough, the organizations are still paying for health insurance benefits. They may still be going to make a pension contribution. So all of us in 2020 can make our pension contributions for 2019. All those things could still occur and happen during that 8-week period.
Yeah. I'm going to do one last question. HHS CARES Medicare stimulus is sent to the practice based on group billing for last quarter. Does the practice have to share this money with independent contractors? For PPP, we don't plan to include independent contractors in our loan application.
I think that's going to be a practice decision. I don't think that the government is going to tell you who you have to share it with. I think their hope is that that money will help you keep the lights on, keep treating patients, keep seeing patients. And outside of the Paycheck Protection Program, maybe you do need it to make payroll this week. Maybe you didn't get that loan money yet, or you don't even know if you're going to get that loan money. So maybe you need that stimulus money just to make payroll. And if your independent contractor is included in that payment, then it's a win-win. But I think it is an organization-specific decision I don't know that you have to include those independent contractors if they're doing their own independent billing. I would suggest maybe they got their own stimulus money. Just things you want to consider.
Okay, I want to end it here. I apologize. We did go over our time limit, but this is such important information that we're getting out. We already have a bunch of requests to do another round, so maybe we could set something up for the next couple of weeks to do another round of this. Again, this webinar was recorded, and if you have questions that were not answered, my email address will be in the email that you receive in about an hour. Please email me your questions, and we will get back to you. Also, if you want the slides, email me as well, and I can share the slides with you. In the email, you'll receive a index number to claim the 2 CEUs that you are getting for this. Thank you both, Brenda and Suzette, for sharing your knowledge. It's greatly appreciated.
And happy birthday, Steph.
Stop it. You're a week early. Either of you have any last comments? We had maximum attendees. I wanted to say that the webinar only holds 101 attendees, and we had 203, 200 and a couple people register. So the first 101 people who signed on were the lucky ones to get on it. So, it'll be available on YouTube to share, but this was great that we had all these attendees from, it sounds like all up and down the East Coast. So thank you, everyone.